Great, thank you so much. Our last speaker of the day is Dr. Douglas Morgan. Dr. Morgan is an associate professor at Vanderbilt University. His central research interest is in cancer epidemiology, prevention in Hispanic Latino populations, and in the US as well as in Latin America. And his particular focus is on gastric cancer, where he does a wide spectrum of research that includes molecular epidemiology, the gastric microbiome, chemoprevention, endoscopy, engineering initiatives for limited resource settings, etc. So Dr. Morgan.
Good afternoon, and sincere thanks to the Institute of Medicine and the organizing committee for the invitation to be with you this afternoon. I'd like to focus on four themes over the next few minutes. First, the connection between epidemiology and how it informs us about prevention programs, with a specific focus on the altitude enigma for gastric cancer in Latin America. Number two, on the disease model, and how that can inform us about prevention programs, and a focus on the microbiome. And then as a segue to specific prevention initiatives, a bit of a conversation about some of the work in Central America. And my focus today is specifically Latin America and Central America. And a few provocative themes that I've been asked to highlight by the organizing committee that have to do with the uniqueness of gastric cancer and how these themes may inform broader cancer control efforts. And these include H. pylori as the most common chronic bacterial infection in the world. Half of the world is infected, and about 2/3 to 3/4 of individuals in developing nations are infected. And then a few questions. Can antibiotics prevent cancer? Can we use geography as a biomarker for risk, and particularly in immigrant populations that may immigrate from high-risk areas? What is the role of the microbiome, both in carcinogenesis and homeostasis? And can we partner? For instance, in areas, particularly in Latin America, where the two main cancers are cervical cancer and gastric cancer, can we partner mobile units or other programs for prevention? 1/4 of cancers in developing nations are due to infections. And 80% of these are due to four main infections: hepatitis B and C, HPV, and Helicobacter pylori. In Latin America, the reality is HPV and Helicobacter pylori. What about the core epidemiology? Gastric cancer we often forget about since the incidence is lower in the West, but it is the third leading cause of cancer mortality. It is a leading infection-associated cause of cancer. H. pylori now has 2 decades of being labeled by the WHO as a class 1 carcinogen. It will rise into the top 10 of all-cause mortality within a decade or so because of the growing and aging populations in the high-risk areas. And in both high and low risk areas, there's a consistent 2-to-1 male to female ratio. It's more of a male cancer, so to speak. But the marked geographic variability makes it different from all other major cancers. And we can leverage this variability for scientific discovery and for focused prevention programs. The high incidence areas are primarily Eastern Asia, Latin America, and the band from Eastern Europe down to the Middle East. In the US, it represents a marked racial disparity. Incidence rates are about double in all non-white minorities. So there's a lot of work to do. What does the classic epidemiology teach us? And this is a summary of the global literature. Smoking and alcohol are associated. Salt and processed meat consumption are associated. A lack of antioxidants or fruits and vegetables are associated. And there seems to be a protective effect, both with endogenous and exogenous estrogens, that may help explain the male to female ratio of 2-to-1, although the biology really hasn't been worked out yet. Much of the disease follows the Pacific Rim. In fact, the majority of incidence follows the Pacific Rim. And there are three interesting enigmas related to H. pylori and gastric cancer. The first, described in the 90s with the discovery of H. pylori, was a so-called African enigma. High prevalence of H. pylori, low incidence of disease. Some of this is biology, and some of this is underreporting. The Asian enigma, a decreasing incidence as one moves from the Pacific to India. But maybe the most interesting enigma, one again that we can leverage, has to do with the altitude enigma in Latin America. And this is this match of topography and incidence and mortality rates. The bulk of disease in Latin America is above about 800 meters or 1,000 meters along the mountainous ranges of the Pacific from southern Mexico, Oaxaca, Chiapas, down to Chile. And this is, it's not related to altitude per se, but probably a clustering of risk exposures, and some of these we'll touch on. And it's not a dogma, so to speak, to be proven, but again, it's something we can leverage, so to speak. And if we zoom in a bit, and here's the mortality data from Colombia, we see this again match of topography and rates. And similar in Central America, this is Costa Rica incidence data, and you see a match between the mountainous regions and higher mortality. But there are exceptions, and you'll see one canton, coastal canton, here in Costa Rica of higher incidence. So, and that highlights the exceptions, but in this case there may be an explanation. Colleagues from Costa Rica explained that this actually was a mountainous community that emigrated 50 years ago for socioeconomic reasons to a coastal region. And so there may be some lessons there in terms of do those from high incidence areas import their host genes and their bacterial genes, at least in the first generation. And so that may have implications for the urban migration in Latin America, but also for our immigrant populations. What about the disease model? What can we learn from this? And I'll present two different views of the disease model. First of all, how do we get there? How do the 1 to 2% that are infected chronically with H. pylori get to gastric cancer? Most have an innocent chronic gastritis. And then subsets progress to atrophy, a loss of the cell mass or parietal cell mass in the stomach, to metaplasia, dysplasia, and then cancer. And really, intestinal metaplasia and dysplasia are considered premalignant lesions. And in the high incidence areas, about 1/4 to 1/3 of those 35 and above have premalignant lesions. What about the epidemiologic model? It's more of a Bermuda Triangle that drives a subset towards adenocarcinoma, and an interaction of host genetic factors and host responses with H. pylori genetic factors, gene-to-gene conversations, an interesting disease model. And then that conversation is modulated by diet, environmental factors, and co-infection, such as with Epstein-Barr or EBV. I'll just pause to mention this is not prevention, but for those of you familiar with the Cancer Genome Atlas Project, gastric cancer is really one of the success stories. There was a remarkable consistency among the various genomics platforms to now define the new molecular classification. And this is, I think, will be helpful moving forward. A bit reassuring that two of our traditional subtypes, intestinal and diffuse, were validated in the molecular era, and also two additional types, including EBV co-infection, was validated as a separate molecular classification. What's the importance? The importance is we can move with specific molecular targets, we can move towards precision medicine over the next decade related to gastric cancer treatment, not unlike breast cancer, lung cancer, et cetera. So this is important. Now, whether we can leverage this for also defining premalignant lesion risk, we'll see. A couple of comments on the microbiome. We're really in the infancy of our understanding, both on the technology side, but also on the bioinformatics side. Some scientists consider this an additional organ system in the body, and with good reason. But also, the changes to the human microbiome in the last 30 plus years or so may not be unlike global warming. So it'll be interesting moving forward as our understanding evolves over the next decade or so. And I'll make 3 comments relative to the microbiome and stomach cancer, or at least stomach homeostasis. An evolving model may in fact be that Helicobacter hands off the baton to other constituents in the gastric microbiome. It's always been a bit of a question. Helicobacter pylori drives chronic inflammation in the stomach for several decades. But then once the individual or the patient gets to metaplasia, i.e. the pre-malignant state, the bug loads drop, okay? Because your acid production becomes less, the stomach becomes less hospitable. There's always been a question, so what are the final drivers? And that remains, and Helicobacter probably does set off certain oncogenic processes, but it may well be that as the stomach is reconstituted, its microbiome changes, and that may be the driver moving forward. Quick comment on coevolution. You can trace human migrations by following the genetic ancestral clonal groups of H. pylori, be they African, European, Amerindian, or Asian. And with that comes the coevolution hypothesis, which may also apply to other chronic infections, such as HPV or tuberculosis, et cetera. But the coevolution hypothesis suggests that if there is a match of genetic ancestral genotypes over time, since there's coevolution, then it should be basically a commensal relationship. Whereas when there is a mismatch, then that's where virulence or cancer risk may play in. And Dr. Correa's group at Vanderbilt did a recent elegant study, again, leveraging this coastal mountain altitude enigma, recruiting patients from the African Caribbean region, low incidence, and the mountainous Andean regions, and high incidence. And what did they find? And what was unique about this study is that in each individual patient, they studied the spectrum of genetic ancestries, not only in the host, but also in the bug. And each of us is a mixture of African, European, Amerindian, and Asian African genes, and each column here represents an individual patient. Humans on the top row, Helicobacter pylori on the bottom row, and mountains and coasts. But what did they find? It was interesting. This is a little complex, and the study was actually underpowered, but there was a strong effect size for some of the subsets. But basically, the percentage of human Amerindian genetic ancestry on the bottom goes from 0 to 1, and then the percentage in that same individual of African strains of H. pylori is seen in the vertical axis. And then you see in the upper right-hand corner is basically a disruption of coevolution, okay? Basically Amerindians with African strains, and here you see the maximum, basically pre-malignant lesions in the upper right-hand corner. So interesting, and whether this applies to other disease models may be helpful, and we hope to take this, or we are taking this to Central America now, and the genetic diversity of the Caribbean Basin and Central America, hopefully not only to validate this line of investigation, but also as to leverage gene discovery and possibly biomarkers. And then lastly, and again, this may apply to a number of chronic diseases and the microbiome, the thinking that H. pylori may actually be protective, or at least some strains may be beneficial in childhood. They may set the immune system to be protective, non-allergic, so to speak, because what we've seen in ecologic studies and in some animal model studies is that in developed nations, or high-income nations, with the disappearance of H. pylori in the middle class and in the upper middle class, there's been a surge or an inverse association with the allergic diseases. And this may also include obesity, inflammatory bowel disease, et cetera. So interesting, but I think one key issue is the following, that Helicobacter pylori is the easiest to measure, or one of the easiest to measure in the human microbiome. So is it a marker for change in the human microbiome, or is it actually a driver? We don't know. But this has implications in terms of interventions to eradicate H. pylori to prevent cancer, because be it the vaccine or antibiotics, you may want to do it in young adulthood rather than childhood if we think it may have a beneficial effect. So those are 3 comments on the human microbiome, basically carcinogenesis, coevolution, and caution, and at least in how we design the studies. Quick segue to some of our work in Central America, and I'll start with a comment on the Central American 4. The northern nations of Central America, Guatemala, Honduras, Salvador, and Nicaragua, are united by history, politics, culture, and language, and really represent a core, if not the core, LMIC region in Latin America. In 2006, they opened their borders and have moved towards economic and, to a certain extent, an integration of their health systems, a bit of a European Union. And I think this is important because now this is a region of 35 million individuals. And if you add the 5 or so million that are here in the United States, it's an at-risk population of about 40 million. And I think one could argue that a regional approach to cancer control makes sense. One of our areas that we've been working in is Honduras, specifically with a gastric cancer initiative, and this is primarily in the western region, a mountainous region, high incidence region, and mostly coffee, with Hispanic, Mestizo, Mayan populations, and just one district hospital to serve a base population of about 1 million, and a reasonable watershed, so to speak, for population-based research. The reality is a stark reality, at least for healthcare in general, but certainly with respect to gastric cancer. A high incidence of the disease in males. Some years it's the #1 cause of male mortality in adults. We see younger patients, approximately 1/4 of patients are below the age of 50. And in symptomatic patients, 1 new cancer in every 10 or so endoscopies. And until recently, most patients came in relatively late and with the diagnosis returned to their homes. We've been able to map the distribution, hotspots, so to speak, and again, this reflects on the altitude enigma, or the geographic variability that we can leverage in the region, and focus prevention. And we're currently doing a national study with the NCI, CGH, to do in El Salvador through a unique marriage between the public and private sectors to also map incidence rates at the county level. And we hope that this will morph into a prospective registry for the GI cancers. This is reality. I won't go through the details of any of the specific studies, but certainly a high population prevalence. Nearly 90% of individuals are infected with H. pylori and with the high risk virulence factors, high prevalence of some of the risk genotypes, and then important environmental and dietary factors. One I'll mention to reflect on the last session has to do with wood stove exposure. Because of the poverty, the use of tobacco is actually not that common, at least chronic users of tobacco. But what is common are the wood stoves. And there are potentially 2 exposures here. One is smoke inhalation, but also organic carcinogens with burnt food, especially burnt meats. And we found, we presented it earlier this year, but a strong association between wood stove use in this setting and cancer risk, basically equal to the main virulent subtype CAG-A of H. pylori. How do we prevent the disease? What are the different levels of interaction to prevent gastric cancer? We do need better biomarkers, but we can consider H. pylori eradication, chemoprevention, and surveillance using endoscopy. With biomarkers, we have some challenges. Currently, there are no proven serum biomarkers for gastric cancer, premalignant lesions, or to define risk of those who might progress. Chemoprevention, as I mentioned, a quarter to 1/3 of individuals aged 35 or older have premalignant lesions in the high incidence areas, but we don't have any chemoprevention agents currently. And globally, the imaging technologies that we use in endoscopy are evolving quickly, but we need appropriate technologies. What about H. pylori eradication? Last year, IARC suggested that we should consider large-scale intervention trials in the high incidence areas. And in fact, in China and Korea, there are ongoing large trials currently. And what is the evidence for this? It's based, the same IARC authors published 2 meta-analyses in BMJ and this year as a Cochrane systematic review, confirming that antibiotics in the setting can prevent cancer. One of the caveats is that the bulk of the patients in this meta-analysis and in the trials globally have been Asian patients. And other caveats have to do with themes we've talked about. One is antibiotic stewardship, i.e. antibiotic resistance, and the other one has to do with the microbiome. And we see this interplay to a certain extent with what we're doing now to treat the epidemic of Clostridium difficile infection, where we're actually transplanting stools. So it's something to consider. It doesn't mean that we should stop and not do anything because we have a window of opportunity to prevent gastric cancer, but in designing trials, we need to move forward with the science and with a certain level of caution. And in our own Latin American H. pylori eradication trial, we recruited individuals from 7 different communities throughout Latin America, and this was really designed to inform us how to potentially design a bigger intervention. Again, community-based recruitment, 3 different arms using evidence-based regimens, and 2 points that we examined. One was the immediate eradication efficiency, but more importantly, a look back at 1 year to discern factors that may be important in designing an intervention and prevention program. And what did we learn? At 1 year, the different schemes are basically washed out. In other words, the specific antibiotic eradication regimen didn't matter. Number 2, the overall recurrence rate was in the ballpark. In other words, if the recurrence rates are too high, then that's not a way to go, at least in Latin America. But I think the most interesting thing that we learned was the following, is that the recurrence rates varied widely by country and by site. And then secondly, younger women of childbearing ages were much more likely, and this makes sense, to have H. pylori reoccurrence. They are also at the least risk for gastric cancer at that particular age. And so I think that instructs us in terms of the geography and also some of the age and gender differences that a one-size-fits-all intervention may not be the best, and we need to be a little bit wiser about how we do this. Quick comment about vaccines. A lot of investigation in the 1990s, not so much in the last decade, but a nice study from about 2 months ago from China, investigators in China. It was a large phase 3 trial done in children, reasonable follow-up, and showed reasonable efficacy of about 72%. But we still have a ways to go, as you can see, both with administration, but probably the 2 most important things, as we've talked about, is 1, we probably need a therapeutic vaccine, and then secondly, it seemed to be there was waning efficacy at the 3-year point. So a lot of work to do here, but it's 1 step forward after a decade, so to speak, of silence. 2 very quickly, last themes. 1 is chemoprevention. We have moved forward in Colombia and in Central America with a chemoprevention trial based on a body of work at the basic science level with an old drug, fluorinathine or DFMO, is approved for African sleeping sickness, has ongoing trials in adenoma prevention, in colon cancer recurrence, and this will be interesting to see how this plays out. And there are a number of other potential agents for chemoprevention in high-risk populations. And then lastly, as I mentioned, endoscopy technologies are moving very quickly. And the question is, what can we do that's appropriate? One of the projects that we're working on with our engineering department is so-called ultra-low cost endoscopy, ultimately with the goal of a disposable system that's targeted about $2 per use. So in summary, I've tried to underscore gastric cancer as an important global disease, particularly affecting LMICs, especially in the higher risk areas, and a marked health disparity in the US. And we can leverage the geographic variability for prevention, and we have a number of areas that we can attack points, so to speak, to prevent the disease. Thank you very much.